Hello everyone, welcome back to another section of Dentistry and more. Today we are going to discuss the last section of previous year question paper that has comes under the topics restoration of endodontically treated tooth, management of traumatic injuries, tooth resorption, and last one is magnification. So we are moving to first topic, that is restoration of endodontically treated tooth, and the probable short notes are post in endodontic restoration, types of post, ferrule effect, and last one is core. Now we are moving to the components of restore tooth, that is the components includes residual tooth structure, restorative components, that is post, core, and luting agent. So in the figure you can see the coronal restoration, core buildup, post, and there is 3 to 5 mm of gutta percha for apical seal. Next one is post. So it is a relatively rigid restorative material that is placed in root of a non-vital teeth for restoration of the core to transmit the forces on the core of the root. So traditionally this endodontically treated tooth, it receives a post to reinforce them and a crown to protect them. So what are the purpose of using this post there? It helps to retain the core, it helps to distribute the stress through the radicular dentine to the root apex. So these are the ideal requirements of the post. It's very important, and a post should provide maximum protection to the root to resist the root fracture. It provide maximum retention to core and crown. Be easy to place, be less technique sensitive, so be visible, be biocompatible. So these are the ideal requirements. You can follow this. Now we are moving to the classification of the post. So this post can be classified according to how they are made. So it is classified into prefabricated post and custom cast post. In case of prefabricated post, it includes metallic post and non-metallic post. And in case of metallic, there is gold alloy, high platinum alloy, and non-metallic, there is carbon fiber, quartz fiber, somewhat like that. And in case of custom cast post, it includes custom cast metal post and core, all ceramic, and polyethylene fiber post. In case of custom cast metal, there is gold alloy, platinum palladium alloy, like that. So this is according to how they are made. Next one is according to the shape. They are classified into tapered and parallel sized. So in case of tapered, there is self-threatening and also smooth sided. Now we are moving to according to method of encagement of the dentine, that is classified into passive and also active. In case of passive, it includes cast, smooth, and serrated. Next one is according to material of the post. It is classified into metal, fiber post, and also ceramic. So these are the classification. Now we are moving to the ferrule effects, a very important question. It's a frequently asked question. So it is defined as a metal ring or band that is used to fit the crown or crown of the tooth. It can be correlated to wine barrels, and the metal band which encompasses the wooden barrel that gives support when the barrel is full. So it's a diagrammatic representation of the ferrule effect. So this figure is very important, and if you wrote this figure or if you mention this figure, you can score more marks. And this one is the requirements of the ferrule, that the axial wall height of the ferrule must be greater than or equal to 1 to 2 mm. The ferrule should consist of parallel axial walls, and the margins of the preparation should rest on the sound tooth structure. So these requirements, this you can mention it. Next one is functions of ferrule. So it includes, it protects the integrity of the tooth, and it reduces the lateral forces, it resists wedging effect, and it resists the functional lever forces. So the functions are also important. Now we are moving to the core. So this core, it is a supragingival portion that replaces the missing coronal tooth structure and forms the center of the new restoration. So it can be available as dental amalgam, resin modified glass ionomers, composite resins, like that. And the ideal requirements includes this compressive strength to resist the intraoral forces, ease of manipulation, low cost, easily available. So these are some of the ideal requirements. And the materials used are mainly amalgam, so as we mentioned earlier, amalgam glass ionomer composites, and its advantages, disadvantages, indications and precautions, these are all given. So this all about the restoration of the endodontically treated tooth. Now we are moving to the next topic, that is management of traumatic injuries. So from this chapter, there is long essay includes that what is avulsion, describe the management, healing pattern and prognosis of avulsion. And the short essays includes classify traumatic injuries of the teeth and explain in detail about management of crown fracture that involving the pulp. And next one is same question as that of the long essay. And third, that is healing after root fracture and avulsion. Fourth, Ellie's classification and describe about root fracture management. The short essays, that is very important, apexification, apexogenesis, cracked tooth syndrome and splinting. So first we are moving to avulsion. So this avulsion, it is defined as complete or total displacement of the tooth from its socket. So mainly this maxillary central incisors are frequently avulsed teeth. And in case of management, there is immediate management that includes the tooth has already been re-implanted to the site, and the patient is asked to rinse mouth, and the tooth is replaced in its socket using gentle or steady finger pressure. After that, it is washed under tap water, and the patient is asked to take to the dentist immediately. And at the dental office, that leave the tooth in its place, clean the affected area with water, saline or 0.12% chlorhexidine. Now suture the gingival laceration. After that, apply a flexible splint for 1 to 2 weeks, and intracanal corticosteroids medication can be placed immediately or shortly following reimplantation, or it is left for at least 2 weeks. And if the patient or parent is not replace the tooth in its or cannot replace the tooth in its socket, then the tooth is placed in a storage medium while transporting it to the dental office. And as we have mentioned earlier, storage media, it includes HBSs, patient's own saliva, that includes vestibule or container into which the patient spits, milk, coconut water, and these are some of the storage media. And this is the management of the avulsed teeth in case of extraoral dry time of less than 60 minutes. And this is more than 60 minutes. Now we are moving to first one is less than 60 minutes. In that case, administer local anesthesia. After that, irrigate the socket with the saline. And now examine the socket for possible fracture or any reposition. And two periapical radiograph from the mesial and distal angulation, they are taken. And also while CBCT should be considered to confirm the reposition of the tooth and rule out the alveolar bone. In case of closed apex, this necrotic tissue is removed from the root surface, and after that the socket is irrigated with saline, and this tooth is replanted gently into with digital pressure. After that, apply passive or flexible splint for 2 weeks and initiate the RCT with 2 weeks of replantation. Calcium hydroxide intracanal medicament for 4 weeks, that is followed by obturation, and the follow-up at 2 weeks, 4 weeks, 3 months, 6 months, 1 year, and then yearly for at least 5 years. This is in case of closed apex. And now we are moving to open apex. It's also same, that is remove necrotic tissue from the root, and after that it is irrigated with the saline, and the tooth is gently replanted into the socket with the digital pressure. After that, the splint is applied for at least 2 weeks, and these antibiotics, they are recommended if there is an infection. And spontaneous revascularization is the primary goal. So if does not occur, apexification or root canal treatment can be done. And follow-up is 2 weeks, 4 weeks, 3 months, 6 months, 1 year, and yearly at least for 5 years, same as that of the closed apex. Now in case of more than 60 seconds, all these are somewhat same, and that is administer local anesthesia. After that, irrigate the socket with saline. Examine the socket for any possible fracture or reposition, and this radiograph is taken. So in case of closed apex, this necrotic tissue is removed and the socket is irrigated and the tooth is gently replaced into the socket with digital pressure. After that, the splint is placed for 2 weeks and RCT is recommended with 2 weeks of replantation. And here this calcium hydroxide intracanal medicament for 4 weeks is done. That is followed by obturation and follow-up is done. In case of open apex also, the first step is similar. After that, spontaneous revascularization, apexification or root canal treatment is done and follow-up is also done. Next one is prognosis. This replanted tooth, it can be monitored by frequent controls during first years, that is once a week during the month of 1, 3, 6 or 12, and then yearly thereafter. And the favorable outcomes include, in case of closed apex, the tooth is asymptomatic with normal mobility and normal percussion sound, and there is no radiograph evidence of resorption or periradicular osteitis, and the lamina dura will appear normal. So these are the symptoms. And in case of open apex, there will be normal mobility with normal percussion, and there is radiograph evidence of arrested or continued root formation, and the eruption is also found. But in case of unfavorable outcomes, in case of closed apex, the tooth will be symptomatic with mobility, or there is no mobility, that is ankylosis, and there is high pitched percussion sound, and in radiograph there will be resorption present with inflammatory infection related resorption. And in case of open apex, the tooth will be symptomatic with mobility or ankylosis, and there is high pitched percussion sound, same as that of the closed apex. And in case of ankylosis, the crown of the tooth will appears to be infraocclusal position. So this there will, in case of radiographic diagnosis, there will be resorption or ankylosis. Now we are moving to the management of fractures involving the crown. So this crown fracture, it involves enamel, dentine and pulp. They are called as complicated crown fracture. So the diagnosis can be patient's history, clinical examination, radiograph and vitality test. The factors determining the choice of treatment plan, that is first one is stage of development of the tooth. In case of an immature vital teeth, this vital pulp therapy like pulp capping, partial pulpotomy or full pulpotomy can be done until this apex is completely formed. Or in case of immature non-vital tooth, the apexification is done using this calcium hydroxide or MTA, that is followed by maturation. And in case of mature tooth, this root canal treatment can be done. Next factor, time between the accident and the treatment. So if the pulp is exposed for less than 48 hours, then this pulpotomy is preferred, and if the pulp is exposed more than 48 hours, then pulpectomy or RCT is more preferred. Next one is associated periodontal injury. That is, pulpectomy is indicated in such cases where the surrounding periodontium is damaged, so and the nutritional supply of the tooth is also affected there. And last one is restorative treatment plan. In case of composite treatment, partial pulpotomy is decided. However, to receive a complex restoration, then pulpectomy is more preferred. Now we are moving to apexogenesis. So this is mainly done in immature vital teeth. This vital pulp therapy like pulp capping or partial pulpotomy or full pulpotomy, it is done till apex is completely formed, that is known as apexogenesis. And next one is direct pulp capping, that involves the placement of biocompatible agent on healthy pulp tissue that have been inadvertently exposed due to excavation of caries or traumatic injury. So these are some of the indications of direct pulp capping, that is pinpoint exposure, there will be controlled hemorrhage, no pulpal necrosis and absence of swelling and tenderness. And the agents used for pulp capping are calcium hydroxide, MTA, enamel matrix derivative, tricalcium phosphate and bone morphogenic proteins. So now we are moving to the procedure of the pulp capping. That is, anesthesia is administered first, that is followed by rubber dam placement. After that, the bleeding is controlled with a sterile moist cotton pellet. Then the exposure site, it is converted by a pulp capping agent, that is followed by bacterial seed restorative material, and the patient should be recalled after 6 weeks to evaluate the formation of hard tissue barrier. Next we are moving to pulpotomy, and first one is shallow pulpotomy or partial pulpotomy. So it is also known as modified pulpotomy procedure, and the materials used are usually calcium hydroxide or MTA, and the indications includes pulp exposure is less than 1 mm in diameter, pulp have been exposed for less than 24 hours, pulp responds positively to vitality test, and there is absence of infection. And the procedure includes, that is, anesthesia is administered first, that is followed by rubber dam isolation. 1 to 2 mm pulp, it is removed with a sterile diamond burr and the copious water coolant with the help of intermittent light strokes. The lost tooth structure is replaced with acid etchant composite resin. So this treatment is considered to be successful when there is no evidence of periradicular pathological changes, no evidence of resorption, and evidence of continued tooth formation. Now we are moving to full pulpotomy. Its indications include traumatic pulp exposure beyond 72 hours, caries exposure, pulp responds positively to vitality test, absence of infection, and primarily indicated if root apex is not yet completely developed. The materials used in case of full pulpotomy is calcium hydroxide and MTA, and the procedure includes anesthesia is administered followed by rubber dam isolation, and the entire coronal pulp up to the level of root orifice, it is removed by using a sterile burr or laser pulpotomy. Then it is rinsed with the sterile saline, and then the bleeding is controlled with sterile cotton pellet. After that, calcium hydroxide dressing is placed, that is followed by zinc phosphate or glass ionomer cement as a base, and it is restored to provide a bacterial tight seal. Now we are moving to apexification. Its indications includes necrosed pulp in the developing tooth with incomplete root formation, open apexes with thin dentinal walls in which instrumentation techniques cannot create an apical stop to facilitate effective root obturation. The materials used in case of apexification includes calcium hydroxide, MTA, tricalcium phosphate, bone morphogenic proteins. And the procedure for apexification is the affected tooth, it is isolated using rubber dam. After that, the access cavity is prepared and the pulp remnants are removed by using barbed broaches, and a file it is placed into the root canal to determine the working length. After that, the canal it is irrigated using 0.5% sodium hypochlorite, and it is dried with pulp paper points. And the canal it is disinfected using calcium hydroxide, that is mixed in a creamy consistency, and it is recalled after 1 week, and the debridement procedure is repeated, that is followed by placement of thick paste of pure calcium hydroxide, and it is mixed with the sterile saline with the help of plugger, and the canal it is backfilled to provide bacterial seal canal. The access cavity is then restored with a temporary filling, and the patient is recalled after 3 months to evaluate the hard tissue barrier. And if the apical barrier is not formed, the procedure is again repeated, and if the apical barrier is formed, it gives a Swiss cheese consistency. And the thickness of the hard tissue barrier formation, it is confirmed radiographically by taking the radiograph, while a hand file it is used with light pressure to probe the apical store. And calcium hydroxide it is removed with sodium hypochlorite along with ultrasonic followed by obturation. Next we are moving to pulpectomy. So it is defined as the complete removal of the pulp to the level of apical foramen, and the indications includes if the exposure is longer than 72 hours during or duration, or the pulp is damaged beyond the recovery, and when the pulp is degenerated or questionable vitality. The procedure of the pulpectomy is affected tooth, it is isolated with rubber dam, access cavity is prepared, and the pulp remnants are removed. File is placed to establish the working length, cleaning and shaping is done. with sodium hypochlorite. Then the canal is dried with paper points and suitably intracanal medicaments is placed. And after that, the access cavity it is restored with temporary filling. And in case of next visit, the canal is checked for any drainage. And if the canal is dry, then the obturation is completed with access cavities restored with resin restoration. Now we are moving to the classification of traumatic injuries of teeth. First one is Ellis classification. There are 9 classes. That is, first one is enamel fracture class 1, class 2 enamel and dentine fracture without pulp exposure, class 3 fractures involving enamel, dentine and pulp, class 4 non-vital teeth, class 5 avulsion, class 6 root fracture without involvement of crown structure, class 7 displacement of tooth without fracture of the crown, class 8 loss of crown, class 9 trauma to deciduous teeth. Next one is other modification that includes enamel infraction, enamel fracture, enamel dentine fracture, complicated crown fracture, uncomplicated crown root fracture, somewhere like that. Now we are moving to types of root fractures and management. So it can be defined as vertical, oblique or horizontal fracture of the cementum, dentine or pulp. So it can be complete or incomplete, and so this fracture of the root can occur at 3 levels, that is coronal, mid root and apical root. And the clinical features include there will be tenderness on percussion and palpation, tooth will be mobile, displacement and bleeding from the gingival sulcus, and also negative response to tooth to vitality test. The treatment in case of coronal root fracture, that if the fracture line if it is above the crest of alveolar bone, then the coronal fragment is extracted. The apical portion is endodontically extruded for post and core restoration. And if the fracture line is below the crest of alveolar bone, it is splinted as for mid root fracture. And in case of mid apical root fracture, first one is splinting, and the tooth exhibit normal mobility without displacement. No splint it is required. And when the tooth exhibit displacement and mobility, the fracture it is reduced and a rigid splint it is placed for a period of 4 to 8 weeks. So this will promote healing, which is verified radiographically, and splinting can be done using composite, orthodontic brackets, acrylic or cast splint, cementation and fiber splint. And most common, the pulp in the coronal segment it is necrose, leaving the apical segment vital. In these cases, this pulpectomy, RCT or apexification of the coronal segment can be done. And when both these segments contain necrotic pulp within, then an endodontic treatment is preferred in the coronal segment, that is followed by surgical removal of the apical segment. So these are the difference between apexogenesis and apexification. In apexogenesis, as we have mentioned earlier, it is defined as treatment of vital pulp by capping or pulpotomy in order to prevent the continued growth of the root and closure of the open apex. But in case of apexification, it is defined as the method to induce a calcific barrier across an open apex of an immature pulpless tooth. Now we are moving to healing after the root fracture. So this root fracture it shows healing in following ways, like healing with calcified tissues in which fractured fragments are in close contact, healing with interproximal connective tissue in which the radiographically fragments appear separated by a radiolucent line, and healing with interproximal bone and connective tissue. Here the bone fragments they are separated by a distinct bony bridge, and interproximal inflammatory tissue without healing, and radiographically it shows widening of fracture line. Now we are moving to cracked tooth syndrome. So cracked tooth syndrome, in this column you can see the etiology, factors and examples. Etiology, this cracked tooth syndrome can occur due to in case of restorative procedures. Factors, that is inadequate tooth preparation and stress concentration. In case of occlusally, there will be masticatory trauma and parafunction, and miscellaneous, that is thermal, cycling and dental instruments. This is the American Association of Endodontists classification of cracked teeth. So you can go through this column. Next one is the treatment plan for the fractured tooth. That is, in case of small crack, the treatment is remove the fractured segment and after that restoration of the tooth. But in case of large crack, that is pulp involved, pulp not involved and hopeless prognosis. In case of pulp involved, that is endodontic therapy with immediate stabilization with orthodontic band. After that, final restoration is done. And if the pulp is not involved, then the occlusal adjustment is done with immediate stabilization and permanent stabilization using bonded restoration. And in case of hopeless prognosis like vertical crack or poor crown root ratio, the only treatment is extraction. That's all about the management of traumatic injuries. Now we are moving to next section, that is tooth resorption. The probable short notes are cervical root resorption, internal root resorption, internal and external root resorption, invasive cervical resorption. It's a classification of the root resorption. So it's classified into three types, that is trauma-induced root resorption, infection-induced root resorption and hyperplastic invasive root resorption. And in case of trauma-induced, there is surface, transient, apical, internal, pressure, orthodontic and replacement resorption. In case of infection, there is internal inflammatory, external inflammatory and also communicating internal and external inflammatory resorption. And last, hyperplastic, that is internal resorption, invasive coronal resorption, invasive cervical resorption and invasive radicular resorption. So this is the classification of root resorption. Now we are moving to cervical root resorption or extracanal invasive resorption. So it is a type of inflammatory root resorption that is occurs immediately below the apical epithelial attachment of the tooth. And some of the etiologies are orthodontic treatment, trauma, bleaching of non-vital teeth, bruxism, periodontal treatment, etc. These are the classification. Now we are moving to internal resorption, that is according to Schaefer, this internal resorption, it is an unusual form of tooth resorption that begins centrally within the tooth, apparently initiated in most cases by a peculiar inflammation of the pulp. So it is characterized by an oval-shaped enlargement of root canal space, and etiology includes long-standing chronic inflammation of the pulp, caries-related pulpitis, traumatic injuries, iatrogenic injuries like deep restorative procedures, application of heat over the pulp, pulpotomy using calcium hydroxide. And the synonyms includes chronic perforating hyperplasia of the pulp, internal granuloma, odontoblastoma, pink tooth of memory. And some of the clinical features includes it is usually asymptomatic until the root is perforated, and the patient may complain of pain when the lesion perforates and the tissue is exposed to oral fluids. And the mostly affected teeth are maxillary central incisors. Usually a single teeth is involved, but sometimes there will be multiple teeth, and it occurs in permanent as well as the deciduous teeth, and in case of permanent it will spread more rapidly. And this granulation tissue, it can clinically manifest as a pink spot where the crown dentine destruction it is severe, that leads to pink tooth appearances. And the radiographic features include outline of lesion, it appears as uniform round to oval radiolucent enlargement of the pulp space, and the root canal, there is distortion of original root canal outline. Next is the type of internal resorption, that is internal replacement resorption and internal inflammatory resorption. So the treatment options includes if that is without perforation, then endodontic therapy is done. With perforation, then it is non-surgically calcium hydroxide therapy followed by obturation. Surgically, there is surgical flap, root resection and intentional replantation. So these are the differences between the internal and external resorption. So definition, you can read. And the canal space, in case of internal, it is oval shaped and it causes expansion of the canal. And in case of external, the canal's shape, it is not altered. And the pink tooth, that is hyperplastic vascular pulp tissue showing through the tooth, and here the pink tooth is not seen, so the pulp is non-vital. Symmetry, it is symmetrical defect through though may be eccentric, and in case of external it will be usually asymmetrical. So these some of the differences are here. You can see in the figure, you can see the internal resorption and external resorption. So that's all about the tooth resorption. Now we are moving to last section, that is magnification. This includes loupes, dental or surgical operating microscopes. First we are moving to dental loupes. So it is classified by the optical method in which they produce magnification, and it is also based on how the lenses are mounted on the frame. So the classification, there are three types, that is diopter, flat plane, single lens or surgical telescope, and last one is surgical telescope with the. So these are classified based on how the lens are mounted to the frame. It's classified into two types, that is flip up and through the lens. And the features of both these are that includes mobility of the lens, adjustment of the optics, ability to share between operators, cost and weight. Now we are moving to dental or surgically operated microscope. It improves the clinical proficiency and deliver better treatment outcomes for the patient. And the parts of microscopes includes eyepiece, lens, binoculars, magnification changer and objective lens. So here you can see the dental operating microscope. Next one is how the dental operating microscope works. To appreciate what a surgical operating microscope can do, it is essential to understand the various aspects of its working. So that includes magnification, illumination, documentation and mounting a microscope. So clinical uses of microscope at different levels of magnification includes low magnification, medium magnification and high magnification. In case of low magnification, it is ideal for tooth examination and initial assess preparation. The wider field of view is useful to gain orientation in relation to adjacent teeth and anatomic structures. And in case of medium magnification, it is most commonly used for most non-surgical and surgical endodontic procedures, and the range of magnification, it provides adequate field of view and also depth of field. Now we are moving to high magnification. It is used sparingly during minute procedures such as instrument retrieval. It also used during documentation of the clinical work. However, the limited field of view and loss of focus of magnification, a challenge during minor movements, make clinical work at these levels of magnification. Now we are moving to clinical application of dental operating microscope in endodontics. So some of the clinical applications are, first one is enhanced clinical visualization of area of interest, diagnosis of cracks, conservative assess refinement, removal of pulp stones and tracing missed or calcified canals, identify atypical root canal anatomy, assessment during shaping, cleaning and obturation procedures, prevention and management of endodontic misshapes, that includes perforation management, retrieval of separated instruments, retreatment of endodontic failures, and last one is microsurgical endodontics for creating smaller osteotomy, inspection of resected root surface, retropreparation, retrofill and microsuturing. So here ends the magnification, and so here ends the conservative dentistry and endodontics question paper. Hope you all understood. And if you have any doubts, you can put it in the comment box. Thank you for hearing my words. Thank you.